Good afternoon, everyone, and thank you for joining us for another Zoom webinar with Dr. John Dounchis. In tonight's presentation, Dr. Dounchis will be discussing the topic, a decade of robotic knee and hip replacement surgery. As always, if you have any questions during the presentation, please use the Q&A function on your Zoom app, and Dr. Dounchis will answer questions at the conclusion. Again, we want to thank you for taking the time to join us here tonight. The presentation will begin in just a moment.
Thank you, Jim, and thank you everybody for taking some of your Wednesday evening to review some of the research and development from the last 10 years here at NCH. We are on the research and development team for the robotic knee and hip platform here for over the last 12 years. And we have some interesting and salient research findings and clinical findings and applications to share with you today. So first, a little bit of review for move into the next slide here. Arthritis. So arthritis in the knee involves the joint surface of the femur and the tibia. So as depicted to the left on the depiction slide image there's a smooth 5mm coating called cartilage, coats the thigh bone femur and the tibia bone leg bone. This 5mm coating has the coefficient of friction less than 1/200th the coefficient of friction between two ice cubes rubbing against each other. So there's amazing biologic properties imbued by a normal functioning cartilage surface. And you can just think of this as a brake pad that coats the femur and tibia bone to provide for a near friction-free environment as the joint articulates. Now, unfortunately, for some of the same reasons that this material has such low friction characteristics, this same material does not have intrinsic healing ability. In comparison to other tissue structures, such as the bone, if you have a fracture, let's say, of the wrist, and you put it in the cast, the bone has the ability to heal. Unfortunately, the cartilage surface, the brake pad that coats the bone, does not have an intrinsic ability to heal. So once it's worn out or injured, unfortunately, it continues to move in a negative direction, as depicted to the right, where the joint surface is worn. And then we start getting injury and damage to the bone itself, deformity of the bone, angulation, stiffness, instability are cardinal signs and features of an arthritic joint. Now, fortunately, many of our patients do well with moderate arthritic changes with non-surgical interventions. Those include therapy, medications, including anti-inflammatories and gentle analgesics such as Tylenol. There are several types of injections that can be particularly applicable to mild to moderate arthritis. Cortisone, Synvisc is the brand of visco supplement that's most commonly used in North America and worldwide for moderate arthritis. And there's a role for biologic and stem type injections in the joints as well. Arthroscopy is indicated with associated mechanical symptoms and meniscal tears in the knee joint. And when these other items fail, we are then considering new brake pads applied to the joints. And that's what joint replacement is. It's a new brake pad or coating applied to the joint surfaces to protect the bones again, allow for friction-free motion, and to restore the normal mechanics and normal anatomy of the joint, and provide for normal mechanics and function of the joint as well. And we'll share further some of the ongoing technological advancements for this arthroplasty intervention. So again, arthroplasty around the knee involves either a partial knee or full knee design. Partial knees involve 1/3 of the joint surface, and full knee designs resurface all 3 parts of the knee surface. So a little schematic to review the range of possible ailments to the knee joint. To the left, a simple meniscal tear scenario with some minor arthritic changes. Those do well with simple arthroscopy. Bone-on-bone arthritis in one compartment of the knee joint does well with just a partial knee procedure. And total knee arthroplasty, as depicted all the way to the right, is indicated when all 3 compartments of the knee joint are worn down to bone-on-bone. So why robotics? Well, in orthopedics, there's been an evolution over the last 40 years in knee and hip arthroplasty to provide tools to the surgical team to best reestablish the new joint surfaces. Again, these are complex 3-dimensional structures with complex joint mechanics, and with better imaging and better data regarding the patient's innate natural joint mechanics, we can better reestablish those articular surfaces to best resemble and best replicate the normal mechanics of that joint. That allows for not only better short-term and intermediate function and optimal physiology, but also allows for longer lasting joint replacement applications. Concept in the end is simple. We get a CT scan of the entire extremity. We have now a 3D model of the entire bone structure. In surgery, we make measurements to ascertain the mechanical and biomechanical aspects to the knee function, not just the ligaments that support the knee joint, but also the mechanics of the kneecap, which is critical for joint motion and function. Once those parameters are identified and established, we can then optimally arrange, initially in a virtually format, the precise location of the joint surfaces so that we can reestablish the natural architecture, anatomy, and function of the joint. And then finally, we turn to the robotic device, which is extraordinarily sophisticated end effector that allows us to prepare the bone surface so that when we apply the new joint brake pads, they're optimally positioned to restore the anatomy as planned in the virtual model. So the surgeon is involved throughout the entire case. It's a team effort with the surgeon and the robot to prepare the bone properly and apply the new joint surfaces in the optimal configuration. So the benefits of the robotic surgery, that only the arthritic portion of the bone is resurfaced, preserving healthier cartilage and bone areas. It's much more conservative arthroplasty than traditional techniques. Allows for better stability and motion, more natural feeling knee. Like a well-aligned car tire, the implants in optimal position will wear much less and provide for more durable configuration. With this technology, small incision and muscle sparing surgery is optimized, minimal blood loss, minimal soft tissue dissection and work, and these are commendable to outpatient surgery and to a rapid recovery. Moving on to the hip, similar concept for the hip as far as the cartilage surface is a 5mm coating and a natural normal hip depicted to the left. To the right, we have a completely worn hip with the bone denuded of articular surface. You can see the exposed bone there. Similar 5 to 6mm thickness coating on both the ball and the socket. Again, this is a ball and socket joint as opposed to more of a hinge joint as depicted in the knee. Here is depicting a routine hip arthroplasty workflow. This shows the abnormal anatomy of the joint. The plan here on the 3D CT information, just like the knee, we have a 3D reconstruction of the entire extremity from the hip all the way down to the ankle. We further integrate interaction between the spine and the hip to optimize hip implant position. The green is a virtual simulation of where we need to ideally place the new center of rotation of the socket, which realigns the worn socket area to reestablish the normal center of the rotation, which is depicted in the purple and green in the center of the cup. You can see all the extra white material exterior to or away or from the pelvis from that surface in the top right there is actually extra bone spurs. You can imagine without helpful imaging and guidance that it's difficult to place the components optimally to restore the anatomy of the hip joint and proper mechanics, loading, and durability of the construct. This shows a typical end effector on the robot for polishing the socket to reestablish the normal center of the rotation and optimal interface between the implants and the surrounding bone structure. This shows some of the workflow. This shows placing the thin titanium shell, which will also have a thin polymer lining on the inside, in optimal position with the robotic system in a schematic format. And this shows us checking the exact position of the components. We know in orthopedics that if we can optimally place both the cup, center of the rotation, and the stem and the hip center, that we can maximize patients' function. Not only do we get the leg lengths perfect, we get the offset and distances for the muscles from the center of rotation perfect, so these muscles can function in their natural optimal configuration. The implants are much more durable with optimally positioned components. The hips are much more stable with optimally positioned components, and long-term durability is maximized as is function. Workflow checking the final positions of the implants as depicted here. The robot is amenable to multiple approaches to the hip. So to achieve the workflow for a hip arthroplasty, the exposure to the hip could be from the front, which is called anterior, and that is our preferred workflow. There is also what's called a posterior approach, which is more from the rear of the hip. The robot can work with either approach. Again, our preferred approach is the anterior approach because this allows us to approach the hip joint without any dissection of the muscle or tissue around the hip. We can leave those muscles and tendons and capsule attached to the hip. This provides for natural and full function of the muscle and tendons around the hip after surgery and maximizes stability after hip surgery as well. Discussion regarding anesthesia for robotic joint surgeries. These involve regional anesthetics. So the anesthesia team places typically a spinal type anesthesia, which is a very tiny thin needle in the spine, allows the legs to be numb for a couple hours after the procedure. We augment that spinal block with some local blocks around the joint and peripheral blocks in the extremity. This, in addition to the muscle sparing exposures involved with robotics and the less involved dissection and surgery involved with the robotics itself as a more conservative procedure, allows our patients to have less swelling, less pain, and more recovery through the phase of intermediate and long-term recovery phase. The majority of our patients are amenable for outpatient procedures. The procedures themselves are typically in the 1 hour duration timeframe. Our patients get up and mobilize typically 30 to 40 minutes after the procedure, full weight bearing, and can resume reasonable activity levels in the first couple of weeks with regards to walking. We strongly encourage bicycling and some gentle weight strengthening exercises in the first several days as our patients' swelling and motion improves. Typically return to activities such as golf is facilitated and reasonable at 4 to 6 weeks, tennis and pickleball by 8 weeks. Again, our focus for the first 4 weeks typically is on range of motion and strengthening exercises. The benefits of both procedures include improving our patients' range of motion and Once the joints are unlocked and the joints are moving properly again, we can really facilitate strengthening the surrounding muscle structure and strength of the extremities. The majority of our patients benefit from a plastics closure with a glue dressing. This facilitates early hygiene vis-a-vis showering without a covering or coating the next day at home. And our patients are facilitated with their exercising with the home therapy assistance for the first couple of weeks after the procedure. Here at NCH, we've been involved with the research and design for robotic knee and hip surgery, both partial and full knee replacements, total, and for full hip replacements for now 12 years. The company involved with robotics is Stryker. Stryker is one of the largest orthopedic companies. They're based out of Michigan. They have been one of the pioneers in orthopedic joint replacement surgery for decades and have been one of the pioneers in robotics now for the last 12 years. They have assisted with the research and development of this project now for 12 years. And many thousands of cases later, we have documented with thorough systematic research that the robotics provides extraordinarily reproducible and precise tool to allow for optimal anatomic reconstruction of the joints as discussed, allowing for earlier facilitated recovery, better full functional restoration of the joints, and optimized durability of the joint construct for many years and decades of high function and durability. Our patients are allowed to resume the majority of expected recreational and professional goals. Patients are allowed to run for sports, tennis, pickleball, softball, baseball, volleyball, etc. We do not strongly recommend running itself as the main form of exercise, as there are better options for this vis-a-vis bicycling, swimming, elliptical, rowing machine, NordicTrack, etc. Or for sports themselves, mobilizing, running is a reasonable aspect to function postoperatively. There are no specific restrictions after the hip procedures and no specific restrictions after the knee procedures. Again, thank you for taking time on a Wednesday evening to share some of the information from the last years of research and development here at NCH with regards to robotic technologies. Again, this is a well-established advanced protocol. We continue to make minor updates to the system as we continue to bring the technological advances to the community here in Naples, Florida.